At least there's one other person who's dressed casually. I don't feel out of place. Can we get started?
Yes, do you want to introduce yourself?
Yes, I do. So I'm Christie Thomas. I'm the medical director of the kidney and kidney pancreas transplant program. I'm a transplant nephrologist, and actually today Alan Reed, who is the director of the entire organ transplant center, and Mike Voigt, my counterpart in liver transplant, were also supposed to sort of come, at least from their point of view, just to meet and greet. But Mike is on vacation and Alan was called to the OR, and so it's just me. But the primary purpose of this meeting was essentially to sort of time for question and answers. I know Scott, I know Musab, I know you,
Mahmoud.
and
Abhishek.
Chaitanya.
okay. So what we are really grateful for is Scott's efforts to develop a new paradigm going forward that utilizes your expertise and your capabilities and your interests to allow us to maintain a fully functional transplant center in every sense of the word. And what we've had is a system where patients who don't need specialty services like ICU care, orthopedic care, are admitted to the transplant nephrologist or the transplant hepatologist with appropriate consultation services coming in. And just like many other services in the hospital that you're well aware of, with resident work rules and so on, we've had to rethink how we constitute a service. And so Scott has been very helpful, helping us think through how we might do this, and I'm here to sort of give you some sense of the a rough idea of where we are going. There's some little details that need to be worked out, and really feel free to interrupt me whenever you want. I am excited about this, and I want to make sure that this is something that you will enjoy doing. I don't know if I was expected to do some education about kidney-specific transplant issues, but maybe I can start off with education. So what I have here is a CD that contains about 7 or 8 presentations on PowerPoint done by myself and my colleagues to our nephrology fellows on issues that are specific to transplant. And we've only given here things that we think you might find useful, such as evaluation of acute kidney injury in a kidney transplant patient, or infections in the opportunistic infections in an immunosuppressed patient, that sort of thing, because you already know how to manage the usual nephrology stuff. So this is just nephrology with a twist. And in a nutshell, we have opportunistic infections, we have elevations in creatinine, and we have drug interactions. So that's a big deal for us, drug interactions. And everything else, you combine it with your experience in medicine and nephrology, you will probably function just fine. So the way we see the service when we come to an agreement collectively, and it's important for us in nephrology and hepatology to do things very similarly or exactly like, and that's where we've taken a little bit of time to make sure we are all in agreement. The way we see the service, as Scott and Mike and I discussed this, is patients will continue to be admitted to us, and that at night you will help us provide coverage, take care of new admissions, and we think that a tight handoff at the start of the night and a tight handoff back at the beginning of the day, initially with the staff certainly involved, because we really don't know what the kinks in the system are. So the staff are going to be heavily involved in the beginning, and if it turns out that the service is light and there's not very much happening, and we agree that the fellow and the PA are competent, then we can just do it with the PA. But in the beginning it'll be us and you doing the handoff. We expect to have patients admitted on 2 Roy Cover West, which is the transplant floor. There's many reasons to do that. One of them is that they are very used to taking care of patients who've had kidney transplants. They know the routine. The PAs that will be helping us during the day live there, and so on and so forth. Having said all of that, the hospital runs at 105% capacity, and our patients are never there even if you want them there, but that's the expectation. other aspect of this is we want to work with you in terms of triage after hours in a way that you find satisfactory. What I think and what Scott agreed would be a good way to do this is that we either take the calls for potential triage ourselves or with you, if that's how you'd prefer it, and then we can decide together if a person needs to be admitted, especially in the beginning. I mean, once you get comfortable and you want to do it yourself, that's okay. But we'd like to make sure it is working satisfactorily, and I can tell you from the nephrology point of view, we're very happy to take the primary call for potential admissions and let you know, or have you join us on the call if that's okay with you. I guess just a quick word on patient population, and I'm going to speak a little bit about liver, but Mike hopefully will do the same thing next week. The kidney transplant population that we take care of are only patients who've already had a transplant, a kidney transplant or a kidney pancreas transplant. 85% will be kidney transplants, perhaps 13-14% are kidney pancreas, and there's an occasional isolated pancreas transplant patient. It's so rare that you don't even have to consider it in your scope of practice. And that's all we take care of. From the liver side, they take care of two populations. They take care of the post-transplant liver transplant patient, but they also take care of pre-transplant end-stage liver disease patients who are on the liver transplant waiting list. So that is I think, a very different population than the post-transplant patient, who by and large should be relatively healthy and is coming in with an acute problem. And the usual types of things that happen on an admission night, if you're going to get an admission, is an elevation in creatinine with or without symptoms. And it might be pain over the kidney, it could be some constitutional or systemic symptoms. It could be an admission with an infection, sometimes a very simple urinary tract infection, but in a patient with a kidney transplant and a single functioning kidney, it becomes a little bit more serious, but in principle it's just a urinary tract infection. Sometimes it's a more serious opportunistic infection, and the two common ones that you will get very familiar with as you do this, and there's a presentation here on opportunistic infection. The two common ones are one that affect kidney function, which is a virus called BK virus, and the second is one that causes systemic disease and sometimes peripherally affects kidney function, that's CMV disease. And again, the presentation typically is very classic for CMV disease. They'll come in with symptoms of a viral illness. Sometimes they'll have pneumonitis. They usually have a reduction in white count. Occasionally they have elevation liver function tests. Often this occurs in the first year and not beyond, and it typically occurs in a patient who was CMV negative at the time they got their transplant and received a CMV positive organ. That's the typical scenario. And again, as you start seeing these patients, you will realize that we routinely prophylax patients who are at risk for CMV for the first few months when they're at highest risk. And so this usually occurs right after that first few months when they're off their infections, off their prophylaxis. And the other reasons for admission are usually a consequence of a drug interaction, where either tacrolimus levels go up very high and you get acute kidney injury from that, or they go very low depending on the drug, and the creatinine goes up, but because they now have rejection. And the things that you sort of have to think about in addition to the usual things you would do with an acute kidney injury would be, do I need to image the kidney to make sure they don't have an obstruction? And again, I want to tell you that not only will we be helping you with triaging, but once the patient is admitted, if you have any questions, you want us to come in, you're going to deal directly with the staff, there won't be any layer of fellows that you have to work with. And we're all happy to come in. About the only time that we might call a fellow in is we need to put in a line to dialyze somebody, because they become better at it than we are. But those are exceptions. And so for the most part, I think from the kidney point of view, these are going to be very straightforward admissions. And if they seem to be unstable enough, they will go to the ICU. So we're really talking about a population, in my mind, of generally stable patients who are not expected to deteriorate suddenly. As I said, this contains some PowerPoint presentations. It also contains some of our protocols that will help you get comfortable with what we do for these patients. For example, there is a protocol here on post-transplant immunosuppression. There's a protocol on post-transplant management of BK viral nephritis. So BK viral nephritis is a cause of silent, slowly progressive chronic tubular interstitial disease. So all you'll have is an elevated creatinine. It almost never has any constitutional or systemic component. So it's just a routine to look for BKV when the creatinine goes up. And so there's nothing that you will need to do at the middle of the night other than consider that in your differential, and keep in mind that BK viral nephritis is a consequence of over-immunosuppression. And if they're coming in with that, or they already have that in their diagnosis, we're trying to keep their immunosuppression somewhat lower, realizing that we're walking this fine balance between too little and too much. And there's no easy way to tell in an individual patient. In a population, we can tell a certain drug level is appropriate, but in an individual, what is therapeutic for one might be toxic for another.
There's no antiviral therapy. Just trying to
There is. So, thank you. So and the protocol for management of BKV is in here, but in principle, the first order of business for BKV is to reduce immunosuppression. In low-level viremia, that takes care of the problem. But then in sequence, we use a drug called leflunomide, which is FDA approved for rheumatoid arthritis, not for BK viral nephritis. Nothing is approved for BK viral nephritis, and it's a problem screaming for a randomized, rigorous, double-blind, placebo-controlled study, but nobody seems to want to do it. Then we sometimes use ciprofloxacin, which appears to reduce BK viral counts, but again, no rigorous studies. And when we are really pushed against the wall, we use this toxic agent called cidofovir, typically used for adenoviral infections, very nephrotoxic. So we try to avoid using it, but we use some strategies to minimize nephrotoxicity, and it's in the protocol. We give a lower dose, we give pre-infusion hydration, post-infusion hydration. We sometimes use probenecid, and its principal toxicities are ocular toxicity and nephrotoxicity. So we don't use it routinely, but we have that option. And I guess in the kidney pancreas transplant patient, the reason for admission, in addition to all of those, will be pain over the pancreas, or a rise in blood sugar, or a rise in amylase lipase. And indicators of pancreatic dysfunction in the transplanted patient is pain, rise in amylase lipase, or a rise in glucose. And it's not a common problem. It's just something for you to be aware of. Even in the kidney pancreas patient, the usual pathology is in the kidney and not the pancreas. Education. So one of the things that we should do is have, at least in the beginning for the first few weeks, have some formal presentations, perhaps of some of these with you. We also would invite you to our regular CME conferences. We have a transplant-specific CME on Tuesday morning in the Transplant Center, 3 floors down, directly down, I think. We have renal grand rounds Wednesdays at 5, and not all of them will be transplant related, but and you can come for any of them, but we can specifically let you know when it's transplant related. Friday at noon, we have a targeted series of lectures for our renal fellows, and about once a month, those lectures are transplant related, and which you're also welcome to come for. And if there are specific topics in addition to all of this you think you'd like to cover, we're happy to come and give them to you. I'm one of 6 people that do transplant nephrology. Musab probably knows all of them. There's myself, there's Roberto Khalil, Chris Blauser, and Sharad Kupachi, and Moni Freire. There's 2 others who you won't see very much of. One is Larry Hunsiker, who was the medical director before he stepped down. He's in phased retirement, and that's why you won't see much of him. But I think he may have 1 block this year. The other is Andy Bertolatis, another person who was here long before I was, who is now only doing outpatient transplant nephrology, and he's not doing any inpatient because he's highly committed to his IRB work, and that's what takes most of his time. So Moni Freire, Roberto, myself, Sharath, and Chris Blauser do the bulk of inpatient transplant work, and all of us will be available. And just like Scott leaves his number around in case you can't be found, I will leave my contact information if you can't find the appropriate person. I don't expect it to happen. And in any case, you're not going to be challenged with something that you have no idea what to do with. These are, if you will, common problems in a patient that has a kidney transplant. So it's sort of just a little twist on a common problem. That's all it really is. I think I've talked a lot. I should stop and take questions.
Christie, the protocols, as you said, that are on the CD, are there orders?
Yes, there are. I can log in. I'll also show you where I might actually. You know what? You're in front of the camera.
Oh.
That's okay. Sorry. By the way, my name is Christie Thomas. On the point, I should show this to you. There are order sets. I should have put this up before. On the point, there are all of our protocols are actually on the point. I don't know if you've gone looking for policies on the hospital site.
Wireless.
Thank you. So there's many hospital policies on that site, but we have a separate folder called Transplant Center. In there you can find a whole lot of protocols. I only printed the ones that I thought was relevant to you. There's protocols on pre-transplant evaluation, there's protocols on outpatient follow-up, there's protocols that have to do with JACO and so on that are really of little relevance to you. But you might find other things in there that are useful. I'll show you where that is. It probably takes a while now to come up. So 8 a.m. and maybe I can send Scott an email. 8 a.m. Tuesday morning, and that's in the Organ Transplant Center, and it's always a transplant-related topic because it's issues in transplantation conference. Some of them you may not want to attend because they're sort of programmatic issues, they're outpatient issues, but some of them will be very relevant on management. We are trying to do a series of transplant-focused M&Ms, essentially to sort of learn lessons from our experiences, just like other M&Ms. And it's actually a very useful thing. The surgeons come from a culture of M&M. Medicine doesn't. And it's been useful for us to sort of learn from them because it's a situation where you have to present a case, talk about complications, but talk about it in a way that's constructive and educational without assigning blame. And they know how to do this. We have to learn how to do this. But it's something I think the department should be doing on a more frequent scale. Okay, so let me show you. So if you go to the point, you're under policies. You would go to, I don't know what that means. You would go to UI Hospitals and Clinics Policies and Procedures, and if you scroll down on the left, you will get Organ Transplant Center. And in here, so the cardiothoracic protocols are here too, by the way. In here are various folders. So here's the kidney folder, and within here, for example, if you wanted to know immunosuppression regimens, they're in here. And it's a useful place to keep them because then we have a single document that is dynamic, so it changes, but it only changes in one place, so people don't have various copies on their own drives. And so here, if you will, are some, again, very quickly, this is how we start our patients. We have them in 2 or 3 different categories. But this is just in principle, just to show you what we do. And it's sort of a mixture of inpatient and outpatient. So we start with induction, hospitalization, maintenance, some notes here. And we try and update this once a year or so. And you'll see that there are some appendices that go with this, how we treat rejection and how we taper steroids. It's scientific management. This is part tradition and part based on studies. Yeah.
So just a quick question. I mean, when we study, you said these are relatively healthy guys coming in
Yeah.
with a common problem. Your threshold for transferring them to ICU would be, is it like a normal population, or you would be a little extra cautious, or?
I think they're like a normal population. I mean, the things that worry you are the same thing that happen in a normal population. I don't think you need to send them to the ICU just because they're a transplant patient. But depending on what they have, they can turn south very quickly because they are. We don't stop their immunosuppression when they come in with a serious infection. We try and reduce what we think we can, and fortunately, stress dose steroids are good for people in sepsis. So we often just convert them to hydrocortisone or solimedrol and take off everything else. If they come in with what looks like a serious infectious process, and then in a day 2 or 3 we have a sense of what's going on. But in terms of a transfer to the ICU, from a kidney point of view, I'd say, if you have any suspicion that they're unstable or they are the kind of patient that requires frequent monitoring, then you should transfer to the ICU. And again, I think in the beginning we're going to be there to sort of help you through this process. It's not common on the kidney side. I suspect some of the pre-transplant liver patients with end-stage liver disease perhaps have a little bit more potential to be hemodynamically unstable. But I don't want to speak for Mike, who hopefully will do this next week. They have some dysuria, little fever, you think they ought to be on IV antibiotics, we'd bring them in. So we have a low threshold for admission. If the graft function's impaired or they have some fever, we'll have a low threshold for admission and probably put them on IV antibiotics, but we make no other changes while we think about, is there another reason for the creatinine to have gone up.
Is it conceivable that these guys might hear from Rachel Miller about it?
Yes, so
She's the ID.
so the two of the presentations on here are Rachel. So Rachel Miller is the person for the service, and by default she's consulted on all infection-related issues, even the ones that we think are sort of simple. Partly because that's how we want to run the service. But you don't have to consult her in the middle of the night. But she's available. In those circumstances, it might be better to sort of talk to us and we can sort of tell you. But yes, we're all here from the work. So here, this is kidney, similar sections of kidney pancreas, and you can see some of these are things you might find useful. So infection prophylaxis, for example, will tell you our protocol for prophylaxis immediately post-transplant for CMV, for Candida, and for PCP. The details aren't important except a patient being admitted in the first 3 or 6 months, you'll see them on valganciclovir and Bactrim and nystatin or fluconazole. And you'll be evident from the you will find the appendices should have more information and some of this is just a repository of things that we want as clinicians, but also things that we have to produce if Jacob walks in. And it's not just Jacob that monitors us. There's 2 other agencies. CMS has now got regulatory authority for transplant programs. UNOS, which is the original transplant oversight body, they all come together on one thing. So some of this will be useful, some not. Don't worry about it. And again, if there's information that you think will be particularly useful and it's not part of our regularly scheduled lecture series, we're all happy to come and talk at your convenience at a time and place, especially since there's enough of us. There are some order sets. I'm not very proficient with it. What I'm going to suggest, because it'll be more efficient, is that next week when Mike comes, I'll have Melanie come with him as staff. We're not very good at finding things in Epic. And stumble through it with you, which we'll do at have Melanie come and sort of show you the order sets. And there's a lot of order sets there, which will make life a whole lot easier. Most of the order sets are the perioperative order sets, but you will find things that are useful in there. Okay, I think, any other questions? Oh, the other thing that we do is twice a week we have something we call joint sit-down rooms, Tuesday afternoon and Friday afternoon, where we discuss the liver and the kidney patients, the transplant surgeons, the transplant hepatologists, if we are present. You're also welcome to come for those. It's a balance between making it educational and making it last for 1 hour and no more. And the surgeons want to cover all the patients. We would prefer to focus on more difficult patients, but it's again a compromise. So it's not necessarily always necessarily educational, but complicated patients, it's a perfect forum to interact with the other services and ask their advice on what to do. Even though they may be consulting, if they're right in the room, it's a much better interaction. And you're welcome to come for those too. So I will send you an email with those times.
That'd be great. Maybe get these guys on this transplant center probably has a mailing list.
Yes. So you will get on 2 different mailing lists, and that means more emails than you might want. One is the Transplant CME conference, Tuesday morning conference announcements, and there's a weekly reminder that tells you exactly who's speaking. And then the other mailing list will be for the renal division's educational conferences, which is the renal grand rounds at 5. There's also, by the way, a hypertension conference on Mondays at 1, but might not be as interesting to you. But again, we'll send you both, all of them, and we'll also send you the fellows lecture schedule for 12 noon, which has about once a month. Those are transplant specific.
What about patients who's been out of their transplant for a few years and they're coming with not really directly related problem to you?
So we try and admit them to our service. If they have, for example, I don't know, what's a good example? A foot ulcer, and it's better off on a vascular service. That might be better. But if they're going to come to medicine and they're stable, they should come to us. And I think it's a good question to ask Mike next week.
How about if they had their transplant at another center?
If they have, I was going to say if they have chosen to make us their transplant center, we are their transplant center, but it's not always true that they've actually made that decision. We have patients who show up in the middle of the night who we've never seen before, who are either passing through or have moved recently but haven't told anybody that they're here. So yes, we take care of them. If they're just passing through, then we just temporarily manage the problem, and wherever they're going to will be their final management. But if there are patients, meaning we manage their transplant-related issues, then we take care of everything.
So the ATC is going to call both of us at the same time?
That's for us to decide. That's entirely up to you. We thought in the beginning we should be on the call, either with you or without you, but that's your call.
If you're on the call simultaneously, then there's 4 people on there, and it gets a little confusing about who's talking and who.
Well, that's one thing. Also, it's like you have to wait for everybody to get on the line too.
Yeah.
And then
Yeah.
you got 4 people.
I mean,
Waiting for each other is going to take longer.
The alternative would be for Christie or one of the other transplant faculty to call you after they.
Yeah.
Yeah, I think that would be that would be.
yeah, I mean, for me, that's a detail. We want this to be an experience that will be useful for you, whatever you do in the future, and some of you might even end up wanting to be nephrologists. So it's never too late, Scott.
Definitely, we would like to be involved in the call.
Yeah.
Even if one of the transplant nephrologists want to page us, or
during at the start of the call, or
at the start of the call. As soon as you get into the line with the.
It's not a problem.
I would think like once you have done the triage and patient is coming.
Triage, once they've done their call us.
Okay.
After the triage.
After
I
the
think
triage,
that would
okay.
be better.
And that will make the discussion easier, like
Right.
between.
Yeah, it would be just one-to-one
Yeah,
discussion.
one-to-one.
Sure,
between
whichever way you want to do this. And if you want to, if you want to wait till Mike is finished and then talk about it, because that's a final sort of little detail.
Just for you and Mike and the others, if it were me in your position, then I would be saying to the ER doc, okay, you can drop off, and then I would say to the transfer center person, could you get the hospital on the line for me now? I'll stay in line, so then I don't have to make another call and figure out who's
Good idea. Okay.
I can operator and the
Good
operator
idea.
knows,
Good idea.
ATC knows.
Good idea.
They
And
do this all the time.
Yeah.
and if you're thinking about volumes, on average there may be one admission from the kidney side every 3 days, 2-3 days. I mean, it's not going to be a busy service. But having said that, there are times when it's crazy busy, and I don't want to sort of give you some false impression. And in the first week, it's all hell breaks loose. But it's not usually like that. And this month has been particularly lean. I don't know where all the patients have gone. It's like they don't exist.
Vacation.
And it's time for new interns, so they're all coming with us.
Yeah, well, these guys are used to peaks and troughs and volume. These guys are like firefighters, and they're sitting in the firehouse, and when the alarm goes off, they go. They're just ready for it.
And we hope to have all the little details worked out with Scott by early to mid-August. Problem this month has been sort of vacations and trying to work around this. So Mike is off the first 2 weeks. I'm off the next 2 weeks. But we're going to try and do this by email and come to some agreement pretty soon. But the essential elements is what I've told you. Anything else? Anything you want to say, since you actually rounded with me on the transplant service?
I think, from what I've seen, is getting the patient to 2RC is very, very helpful. The other floor, the nurses, for example, even drawing labs, trough levels, medications, all of that, it's more helpful to have them on 2RC. So
it's a very important point. So one of the big hassles on every other floor is trying to get a trough tacrolimus or cyclosporin level that we can hang our hats on. And remember, if this is in the context of a change in creatinine, it's really important to know, and we can't wait 3 days. And on the transplant floor, labs are drawn at like 5 in the morning. When we come to round at 8 in the morning, results are in. And every nurse and phlebotomist knows that they get their labs drawn before they get their morning tacrolimus. It almost never fails. But on other services, depends on when phlebotomy comes, depends on what you put in EPIC. We can put whatever we want in EPIC. It will only be given after the blood draw. So that's a very important
And
point.
you can always tell the nurse that it has to be drawn.
Yeah.
Works.
But the problem is you have to remember to tell them,
Yeah,
and
if you call them, yeah, if you call them.
and then there's a handoff at night, and there's a floater that comes on, and it's a difficult needle stick. I don't know, but we see this on other floors, that it's such a hassle sometimes to get a level that we can depend on. Fortunately, they're admitted to orthopedics or some other service like that. The level isn't critical, because that's not what they're in for. But when they're coming in to us, it's usually an important problem.
I can tell these guys a funny story on my part. I have a special interest in transplant myself, and I did my electives on 2 months on the transplant service as a resident. And things have changed, obviously, since then, in the suppressive drugs and so on. But one of the fellows on the transplant service at Wisconsin is Alan Reed, who's the chief of transplant now. So it's a small universe.
Actually, maybe you should also tell them about John Persh.
Yeah, and there's at Wisconsin, there's a very good transplant physician who's a general internist who does a lot of the research and a lot of the immunosuppressive medications at Wisconsin.
So he's a highly regarded senior transplant physician who manages kidney patients, who is not a nephrologist. Just goes to show.